that is inflammatory response. If you see that it's thick and there's no wall distinction, in that case, I worry about the malignant stricture. Or malignant stricture, that is, I'm talking about the infiltrative process. But malignant stricture many times have a kind of a mass effect around the bile duct too, so it might be growing outwards. So in that case, that becomes much more clear, and you can biopsy that. So wall distinction, likely wall layers distinction, likely benign. No wall layers distinction, malignant versus fibrotic. So it's not that easy sometimes without biopsy.
To the extent was known for edema without cancer was the 18 years are okay, but then those 3 years are not visible.
Or they are not always visible. Like you have to really, अगर कोई होता है in one of the next cases, if there is an inflammation of the bile duct, if I can show, I will show it. But, okay. So we'll see if it's we can find those layers. So main, this is, I won't go into too much details of everything, mainly talking about FNA, FNB, ROSE, MOSE, macroscopic evaluation, choice of needle, what needle should be used for what lesion, and then I have some slides, actually how to make the slides, and then how to interpret those slides during the EUS. So we'll go through that based on how much time we have. We can do that. How many more cases we need to do? 4 more? So should I finish this in 30 minutes or less than that, or 20, 25 minutes? Got it. So this is, I really like to give, whenever you are talking about any procedure, it's a good idea to know a little bit history, not details, but EUS basically started in 1980s, and that was initially, it was a diagnostic EUS. The people who were doing EUS, they didn't even know what they're looking at. So just it took them time to determine what those wall layers are, what it looks like. But what I want to tell, or I want to say is about first FNA by EUS was performed 3 decades ago. Anybody knows who did it? Good. Dr. Peter Willman did it in, he still practices, I think. It was a FNA of a mediastinal mass, lymph node, actually. So that's when it was. And then, obviously, after that, a lot of refinement and EUS role in staging, except the luminal cancers where it still has a good role. The role in staging of pancreas cancer and otherwise staging and post-treatment staging like chemo, after chemo radiation is decreasing quite a bit. Our MRI, CT scans are getting a lot better. But it still does really good for luminal staging, initial staging, and also have a unique prospect in cases of submucosal lesions, where it performs really well. Needles. There are how many needles in the market? Like every company makes needle, pretty much. And it becomes difficult to choose one, and a lot of it depends really on available resources, what is available to you. So all these needles, what I would say, what is the needle secret? I won't say that all needles are equal or they perform equal, but you can find any needle, you can find a way to use it and make it perform better. So what I say is every needle works. You just need to figure out how. That does not mean every needle performs equally. So there is a little bit difference on what type of needle you are using, what technique you are using, and what technique works for you. But just whatever is available to you, just figure out how to make it work. It will work. Okay. What do you want from a tissue? It has to be, if it's a cellular, it's adequate. Ideally, only one needle use. And what you want to avoid is the blood in the specimen. So what technique in that would you use to achieve that? I'll come to that in just a second. By the way, I feel like the most difficult lesion to biopsy is really not a pancreas, it's a submucosal lesions. And because they sometimes move away from you, and especially if it's a smaller, so level of difficulty, they're the most difficult, then unsnit process probably, then rest of the pancreas. The easiest area to biopsy is anything periesophageal, or when the scope is straight for you. Some of you already know about these definitions, but good to know cytology. What is cytology? Cytology is individual or small group of cells. What is cell block? Like you put that specimen in a preservative. I don't know, what do we use here? Formalin or cytolite? Formalin for all the FNAs? All the FNAs. So formalin, cytolite is a separate solution. If you have a good tissue, it likely is better to put it in formalin. That is a better preservative. And but that it goes to the lab. They make pellets out of it, and then they cut it into like a very fine cuts after it is embedded into paraffin, and then do a H&E staining. Core now use the needle terminology. Core is a tissue where the architect is intact enough with the arrangement of cells that there is a stroma. A lot of us were requiring core because of this a more molecular genetic analysis, individualized treatment. So a lot of these oncologists and also cytopathologists, they're asking for core tissue so they can do studies of that specimen at molecular levels. Okay. Yasbhai, how many units have a cytopathologist available? Hardly any. How many have a cytotech of their own in the unit? LGH, you guys have cytotech, or you make your own slides? And probably no, but here? You have a technician? Okay. I think these are the two main units I can give an example. They make the slides. And what about here? Wasim is everything? Okay. Yeah. So that's what I'm saying. Like, you have to look at resources, what is available to you. For here, like, to me, cytotech is available. Actually, I have two cytotechs in the unit. But in the unit where we perform 15 to 20 USs every day. So we can afford to have two cytotechs, okay? So here, cytologist is available to us, 2 minutes a walk. So that's a different, not even in USA, that's not available in every unit. But I have learned to make slides. When it's any case after 5 p.m., and if the cytotech is not available, I make the slides for my team, like anybody doing it. I make the slides, I interpret it as well if we have enough specimen or not. So what I'm getting at is, for you guys, you have to learn, or your technician or whatever your staff is available, need to learn how to make slides, how to stain them, and how to interpret them. That you should learn on your own. just because you don't have those kind of resources available. So for us, in-room cytology available, FNA is still not a bad needle, especially smaller lesions, bile duct, small lymph node, bile duct wall, small lymph node, and any cystic lesion. Use a FNA needle for those. Cyst, any fluid, any cystic. Because what happens if you use a core needle, there's a high risk of bleeding in there. Okay, so if there is a fluid, use a FNA needle. And if you have other resources available, like cytotech or cytopathology available on site, then you can use a FNA or FNB needle. Actually, if you don't have it's a solid mass, and if you don't have cytology available and you just are going to put the specimen into the formalin and you don't know how to make slides, better to use FNB needle for solid lesions. Get the specimen and just put it into the formalin and then send it to the lab. And what you're looking for is a tissue, not a blood clot. The tissue is going to be looking white, and if you see it's all red, you can shake the specimen a little bit, and sometimes the clot separates from the tissue and you see the white specimen in there. So that's important. I won't go over that rows, because it is proven that if you have on-site cytology evaluation, rapid on-site evaluation, then that always helps you with the adequate specimen. Also helps you with the you're biopsying the right area. Minimize the number of passes needed per procedure, and also decreases the inadequate final diagnosis. So I won't no need to go into details of FNA technique or FNB technique. The question is always, one thing is we all know about the fanning. Fanning, I think I mentioned quite a bit yesterday too. You go into the lesion, if it's a core needle, you just want to go in one area just once or maximum twice. Then bring the needle back, not out of the lesion, bring the needle back to the surface of the lesion. Ideally, for me, the first thing I use is maybe move the wheel a little bit away from me or towards me, and then go in the lesion. Even if I don't see the needle completely, by changing the direction with the wheel, that would take me into the different area of the lesion. So I'm not just going back and forth into the same area. If it's a FNA needle, you can do 3-4 times in one place, then change the direction. Total FNA passes could be 12 to 16, but if it's FNB needle, many times you get this tactile sensation, like when the tissue is coming into the needle. If you feel that, when you develop that sensation, you go in one area, no need to go back into the same area, bring the needle back and change the direction. Usually you don't need to do more than 4 or 5 times. Sometimes if I'm thinking if I'm going to have only one chance at biopsy, I don't want to keep going back and forth in that lesion because of the vessels around, or I'm not convinced enough, really I need to keep pushing for more tissue. In that case, if I'm going to make one pass, I may just do more than 4 or 5 times, maybe do 6, 7 times even with the core needle. But always try to go into the different area. Next is suction, no suction, capillary technique, style it, no style it. Just do what works for you. For me, if it's solid, I do not like suction unless I don't get any specimen after 2 passes. Okay, if it's a dry specimen. And in that case, I will use suction. And I like to use intermittent suction. What I do by that I mean is, I'll show you, like first pass, first few in and out of the lesion, I will use no suction, then turn the suction on, do it 2-3 more times, then turn the suction off, and then do it 2-3 more times. So at the end of which I'm doing, like back and forth, I don't want to use suction because suction always pulls the blood in there. So I want at the tip of the needle, or the most distal part of the needle, without suction, even when I'm using a suction. If it's a fluid, you need a suction. If it's a solid, I don't use suction. Stylet, I don't use it. The needle comes with the stylet inside, so I will use that in the first pass, but after that, I don't need it. But sometimes people use a capillary technique, means uh, when a stylet is in there, it's a little bit pulled back. So when you go into when you are going into the mass, your tech is pulling the stylet back. So that kind of the concept behind that is it creates a negative pressure into the needle. So help you pull the tissue in there. So yes, that might work, might not work. For me personally, as I said, no suction, no stylet. For solid masses, if I'm not getting any tissue, intermittent suction. For cystic, any liquid, suction. Okay? So this is one of the solid lesions. I think I'll try to skip a little bit. Here, there's an other thing is what I call when the needle comes out. You'll see in just a second, hopefully it comes out. When you are at the wall, especially the gastric wall, when you get the needle in there, just do a little bit what we call a tenting. What the tenting does is the sharpness of the needle is kind of, you will see that I'm just gently going to push in first to stabilize that sharp edge of the needle, or the Francine needle, I think acquired needle, you have that access to that. It has 3 cutting edges. So those 3 cutting edges are sharp edges. When you gently push onto the wall, especially in cases of stomach, it is needed. It kind of stabilizes you. It kind of digs into the mucosa. So then do a little bit, 1 millimeter more tenting on that. After that, you can't do this. It's never gonna go in. You have to stab it, but it needs to be a controlled stab. So you can either lock you open that screw before the needle moves down. You can lock it at like 3-4 centimeter if you are worried about you're gonna pass too deep in there. But I put my fingers on there and use those as a stopper for the needle. But it needs to, after you're ready to puncture it, it's not this. That always is gonna, if you are in duodenum or esophagus, it's gonna be okay. But for the stomach, which is a floppy organ, thick wall, you have to stab it, but controlled stab. That's how you do it. Okay? And this is the, I think, this is the Olympus needle I was using. I had to make a video for them, so I think I'm just showing it how I use that intermittent suction. You can see the suction on there. I don't think it's on. Okay. So first one, I go in, few back and forth, no suction. Then I'll open up the suction back and forth few times. And then after that, close the suction again. And then the last part, I want to do it without suction. Okay. I think really for me it does. And if you feel like it's not, complete suction is not making any difference for you, like whatever works, honestly. That's what I say. It's like, there's no consensus. If somebody tells you this is the best technique, what they really means is that what works for them. It's if something which works for me, I always say that. All these randomized trial, I can tell you if one thing works for me, I can give you 100% guarantee. I can do a randomized trial and prove everything else is wrong. My technique is superior. So don't what I'm saying is if I want to do even in a randomized trial, if I favor one technique, I can make sure that technique, even in randomized trial, is better. So it's really all these randomized trials of needles and this and technique and all that stuff. It is one for people who like one technique. They're so used to that. They have mastered that technique. So they can prove that that works. That is the best technique. So that was the first part of the talk. So I already talked about that. It just depends on the resources. ठीक है हाँ तो मैं ये भी पूछ रहा था कि हाउ मेनी people have
Was in your experience F&B when you're doing, how many passes do you make and average how many times do you have to actually, when you go in the first pass, how many times do you do in pro and how many times do you do more than one pass in F&B?
so that we also kind of discussed uh, yeah
मैं मेरे को तो फीडबैक क्योंकि याद है ना कुछ होते हैं इंस्टीट्यूशनल माइंडसेट्स अब असल में अगर आपकी अपनी सेटअप में इंस्टीट्यूट नहीं हो रही सेटअप नहीं हो रही तो माय इम्प्रेशन दैट एवरी टाइम द सैंपल गोज आउट वहाँ से ये लिखा आ जाता है AW सैंपल रिपीट डिवाइस तो इसलिए मेरा तो एक बेस्ट दैट वी नीड टू हैव our own setup within our own department if we are doing such an expensive procedure and such a high-tech procedure. It's always good to have somebody in your own department trained for that and develop in-house facility of doing histopathology. Immunohistochemistry के लिए बायोपिक बात है लेकिन ये in-house रखने की कैपेसिटी होनी चाहिए.
Our this is absolutely right. This is a big problem. The big problem, the bigger problem is that they're very, the side of the colleges, hiring them in the government setup and institutional issue that we face here, I don't know what you side to do. And what I was thinking was कि मैं उस तरह because इसमें कोई hands-on का involvement है, it's more meeting and one of the thoughts I had was कि अगर कोई ऐसा interested मुझे मिल जाए या मैं एक दो लोगों से फिर हम उनको बाहर भेज दें वो सिर्फ किसी पे करके वापस आए but then as soon as they come back why would they want to work for the government because वो तो पोस्ट कर लेंगे यहाँ पे प्राइवेट सेटअप इतना स्ट्रॉन्ग है कि वो आप गवर्नमेंट सेटअप में रोकना इतना आसान नहीं जितने भी अच्छे लोग आते हैं वो 2 मिनट में वो प्राइवेट सेक्टर में चले जाते हैं द रियल टाइम सो what we've started doing initially when we started doing F&B I stopped paying attention to those because this is what the general consensus was but then now we've gone back to this so every F&B we do we have a look because वो वाली आपकी बात ये सैंपल भेजा है नज़र आ रहा है I've seen it I know it looks pretty good and वहाँ से जवाब आ जाता है कि
we are doing rules for everything. So even with the FNB needle, we have a good tissue specimen. Okay, I'll do it. You coming back? Coming back?
After a very long time, I have
Okay.
I'm coming back. Alhamdulillah, never had one. अभी
अच्छा वो आपके मान लेते
एक था ना बॉस, वो परमानेंट बॉस की बात। That is permanent in life. वो आपको मतलब गलत तरफ चले गए।
क्यों उधर दुखती रग पे आप हाथ रखते हैं
बात है कि आपको सही कोई बात कह दी क्वालिफाइड स्टेटमेंट
ठीक
तो उसको क्वांटिफाई करना
ठीक So technical tips, I think I kind of said that all, but if you are looking for cytology only, I mentioned about small lesions, bile duct wall. In those cases, maybe just use a FNA needle. Needle comes with the stylet, so I don't take it out with the first pass. I will take it out. I don't use it for the next pass. If suction only, if I'm not getting any specimen, fanning works better. If it's a really, really large lesion, I kind of mentioned that yesterday too. There's gonna be necrosis in the center, so try to take a specimen from the periphery of the mass, and especially in center, if you see the heterogeneity and some fluid, avoid that area because that is all necrosis. So you won't get any specimen there. And to Dr. Gas' point earlier, even though if you get a core, you can put it in formalin, send it to the lab. But if answer comes back inadequate specimen, that could be problematic. So we do make slides. And as I mentioned, if I don't, even after 5 p.m., I have on-call cytologist as well as cytotech. They are available. And here and there, I just make a fuss out of that if they are not available, just to, even though I may not need them. But sometimes I do FNA or FN here and there every 2 weeks, once at 6:30 or 7 p.m. So make sure somebody gets called from home, so they next time they will be still available when we need them. So I think I probably misspoke on that. Yes, you have to pull it back because it's at it. Yeah, completely. Yes. Yeah, you have to pull it back. And what I meant by that, because stylet is in there, I would not tell them to completely take it out. Okay. What I meant was that I'll leave it in, but you have to move it back up a centimeter or two because the stylet goes beyond the needle. That is just to protect the sharpness of the needle. And it's a safety as well. So you have to pull it back. Except I think Cook needle doesn't have like that. And Boston, yeah, Michael. They both need to be pulled back. And there is another needle, I think Boston acquired, just made another needle where the sharpness is in the, actually in the needle part is the stylet. And the rest of the needle is the core and pull नहीं करना पड़ता, yeah. That's, yeah. Actually, if you pull it, you will never get in because the needle, your needle is the stylet. But the problem with that is when you have to express the specimen, and especially if you're doing a liver biopsy, it's just going to fragment the whole tissue. And also pushing through that, there's a small chance of crushing the specimen because the needle part would go first into the tissue, and then you are just kind of crushing the specimen inside the needle. So, but that is available. Okay. जी जी तो it is like majority of the time the problem happens when your scope is in a long position. You are using an elevator and you have to move the sheet back and forth with the first or the second pass. What happens is after the second pass, our first pass, second pass, you using an elevator and doing a pass because using elevator to fan or just, and then forget to release the elevator before you pull it back. So the needle, like elevator is still on and people, tech pulls the needle back or you pull the needle back. You already pull the needle is already secured, but you pull it back, stylet is, it has to come through the stylet, that force, so it gets bent. So that is going to give trouble after second or third pass. So it's just, or also if you're having a trouble passing the needle, like when you're putting it in and last 5 to 10 centimeter, giving you a lot of trouble to get through because your scope is in an awkward position, it's bent, and you try to push through that, that also damages needle. So it's really is, and also quality of needles. Some companies' needles are better quality, no question about that. And so it also depends on the needle as well. So different, if I have to adjust the stylet, I know that I will have to adjust that pretty much every time. And don't try to push that. The needle through the scope. Needle should move gently through the scope. Pull the scope back. That would protect your needle. Okay. Slide prep. One slide smear. You put that specimen onto the slide. Use the other slide at a 90 angle to that. Press on that, and you move it back. two slide specimen. If you want, you have a lot of tissue on there, you want two slides from the same specimen. In that case, you put that specimen on that and put that second slide right on top of each other like a parallel, and then press it and make the slide out of that. Here, touch imprint, I think I mentioned that yesterday too. We talked about that. You put the specimen on there, and then you kind of use a tweezer to either touch it or roll that specimen over the slide. So this is one of the examples of one slide prep. If you look at the specimen, it looks like a blood in there, but you'll see it's a good specimen when you make the slide on there. Put the slide right on there, gently press on it, and then it's a one quick movement over the slide. And then the same one on the second one, you just press on it and just pull it back. You see that? Even here, you see the tissue on there. That's a good tissue on there to stain. Okay?
This is mixed with some kind of solution?
No.
This is simple.
It's just a specimen out of the needle onto that. Yeah, nothing is mixed there. Okay. It's not stained yet. You gotta stain afterwards, right? We just saw that, right? Yeah. Okay. Okay. This is, I think, yeah, this is kind of a touch imprint. So you pick that up and you can just like roll it over based on how much tissue you got, and you can just touch that on the slide. And that will leave the cells from the surface on there. If it's a FNA specimen, that will also leave some stroma. If it is not a, if it's just a biopsy, regular biopsy specimen, that is just going to leave some cells from the surface. Okay. These are the stains we use here, right? As Yasmin? Yeah. There's a fixator, then there's a blue, that a nuclear staining, and the cytoplasmic stain, pink on that. Okay.
And remember to change them after every 30 days.
Yeah. I would actually. नहीं बॉटल हमारी वो बॉटल्स जो आती है ना छोटी बॉटल ओ यहाँ पे बॉटल अच्छा बड़ी बॉटल yeah we have like those small, they come in as small bottles, and every single specimen have a different set because there is a risk of cross contamination when you're making slides. What is this? Anybody? Anybody sees any cells there? Ali? Nobody say? Not really. Okay. What do you see? I think all possible. It's more like the mucin stains like that. Okay. Yeah. Acellular. It's a kind of a blue, just looks like a fibrous tissue, but there really is not a fibrous fibers in there. And it is still kind of an adequate specimen because if you are in a mucinous cyst, that's what you'd like with it. And sometimes you will get cells. If you do get cells, then you want to study those. What I do for the cystic lesions, this is my own way of doing it. I aspirate the fluid from the smaller cyst and rotate the needle. I leave that needle in when the all fluid is aspirated. I get the needle and spray it off the wall of that area. And I may not see the wall, but I'll just stay there and just move the needle back and forth a few times in a very small contained area, hopefully with the hope getting some cells. And then what I do is, because the cells are going to be on the tip of the needle, so I'll make a slide out of that. Okay. What is that? Anything in there? What is it? I hope not. This is called a junk. Okay. So means all inflammatory cells really. So when Our cytotext sometimes are like, is there a good specimen? They call it a junk. That means really all inflammatory process. And what is that? Hmm? Why? It's normal what? It is normal, but what normal? Normal pancreas, ductal cells. And what are the other ones? Other slide. Where do you see adenos here? No, it's inside. You see the cytoplasm? They're acinar cells. Normal acinar cells. Because they're pretty much, I'll show you the abnormal ones. If you look at those, they're pretty much same size. And if you look at the cytoplasm, it's not like a nuclear ratio is not, you see a clearly cytoplasm in there. So ductal and acinar cells, there could be a majority of the time what we call an adenocarcinoma is a ductal cell carcinoma. Okay? And ductal cells, they are kind of sheets, but acinar cells come as a groups, but they are separated cells. And acinar cells, there could be a cancer of those, rare, and there is a stain they do for that to differentiate that. Which one is that? Chromogram? Trypsin. I was going to give you, I was going to bet some money on that if anybody knows that. Yeah. So this is, I think it's not very clear. I'm going to just take the, I'm going to go to the next one. Okay. Now look at that. Here, these are the main features of cancer, adenocarcinoma. Number one, pleomorphism. Means, what is pleomorphism? Different sizes. In adenocarcinoma, we want at least 4 different sizes. And all those are bigger than RBCs. Okay? So here, RBCs, you see that on the side right here. There are like, this is different from this, and there are at least 4 different sizes of that. So next one is high nuclear to cytoplasm tissue. Pretty much cytoplasm is common, and mostly it's the nuclear. Then hyperchromatin, really, really blue cell nucleus. And sometimes you see those dots in here. That also is like blue dots, a lot of chromatin. Okay. And then this thing we call a multinucleated tumor cell. You literally see the mitosis in here. And they're like 2 nuclei together, they're separating from each other. They're not macrophages. The first one was the macrophages, which can look big, and then yes. You see some cytoplasm around it, and so that's the
One cell is not overlapping two cells.
no, they're not. Okay, this one is such a cell. Yeah. And also, likely not overlapping, because look at the chromatin here, and different sizes, they're big compared to the RBCs. So this is called a giant cells. Khandani. Yeah. Family level badi hoti jayegi. Okay. This is that we were talking about trypsin stain. Okay. Neuroendocrine tumor. We all are such a big fan of neuroendocrine tumors. And so this is what you see, high cellularity. Whenever you see those small blue cells, the one which were looking like a normal can look like that. And neuroendocrine can look like that, those small cells. Even though normal you saw, I'll show you the difference how it is. Small cell cancer can look like that, and lymphoma. Lymphoma, you will just see sheets of blue cells, but individual blue cells. Okay. And with the neuroendocrine tumor, we'll talk a little bit more different. Actually, there are the features on there. I'll show you some. What I usually look for these cells is like there are going to be a lot of those cells, and if I can see, these are called fried egg container cells. You see some cytoplasm, but you see a yolk on the side. So when I see these small cells like that, and if I can find those cells in there, like it looks like a fried egg, that usually is a neuroendocrine tumor. Okay. I think that's, oh yes. What is this? I think we did somebody asked me about this yesterday. It's not spindle, it's the solid pseudopetroleum. And why is that? Why do you say that?
Fibrosis is like in 3 years.
So you see this, like, I call it like grapes with the branches. Okay. So you see all the fibrosis right in the center, and there are individual cells just on the branches. So that is a very typical of solid pseudopetroleum. Okay. Oh, I was going to ask what stain you use for GIST, but it's right there. Okay. It's more like a yeah. It's a what is the difference? Why you brought that up?
Those cells are spindle normally, they are spindle cells. These are yeah, the 10% we have mixed variation.
Yeah, it's look more spindle cells. If you see, it's like literally like spindle, smooth muscle cells. What those are, and in this one, sometimes there could be more like a cellular component to that. So it's got apically light chest. Take-home message. I think that's enough. And the biggest take-home message is what is the which needle should I use? I keep saying that. What works for you? And other thing is, really nobody cares. You can keep saying my needle is in the lesion. They don't care unless the lesion is in the needle. Okay? That's the whole point. That's the like really the gist of it. Like you need to have a lesion in the needle. That's it. And whichever needle works for them. The one which is available. That's number one. Absolutely. So the one which is available and works for you. Okay. And the one which is available, make it work for you because you have no other options. Okay. I'll add that. Okay. And this is our center where I work. And our team, team has grown tremendously. We have a staff of over 70 people who just, it's a just advanced endoscopy. I was just telling Dr. Gyas earlier, we did 950 advanced cases last month. That included over 300 ERCPs, I think 350 USs, and we do a lot of EMRs, ESDs, POEMs, and Zenkers, you name it, we do it. ESG, you saw that too. TOR, stenting, double balloon, everything. Okay, thank you. We are on the lake on the other side. In this building, it's right on the lake.
So this will be the nice view. And this will be the nice view.
Yeah, and it's kind of like the sitting area is a very nice view. That is the most prime location of the hospital, and I'm not willing to give it up just because it's such a prime location. But the space is very small for us. So instead of giving up the space at that location, we decided to have a second unit in another hospital.
Could have said it's a B-side hotel and I wouldn't believe you.
What?
It could have been a B-side hotel on top and I would have believed it.
It-
five-star,
Yeah, yeah.
एक होता है seven-star होता है, seven-star होटल होता है, ये seven-star hospital है।
Yeah, this is the lake
तो
actually.
निकलने का दिल नहीं करता।
Yeah. This is the lake right outside our office. Outside our office. That's the best company. Yeah. And this is our team. We're hiring a seventh one. We are the busiest center in the U.S. More than anybody. We do, as a combination, as a team, we do more advanced cases than any center in the United States.
And you are the head of the center.
Yes. Okay. Any questions about FNA? Yeah, that's it. So myself and Dr. Jain, right here, he's and then Mustafa.
Yeah.
Mustafa. And Tom Reeves, this is Dennis Yang, and this is Matthew Cosgrove. We hired, and in the process of hiring another female.
I accept.
Huh? No, I'm
So we have 6 patients, and I think we need to do 4 more cases for every candidate, if I'm correct? Or do we have, okay, 4. So, we're gonna be using 1 room at a time. There is a rectally US patient had a vaginal trauma delivery, so I think that could be something that we could just do, not for the candidate, but as a live session. Like,
What is the issue about that?
this patient has something that is delivery, we were grade 4 and
Oh.
now
So it's
we have
Specific